Welcome to the Health and Wellbeing Podcast, a new series from global technology services provider NTT that explores the digital transformation of our everyday welfare. On this episode, how do we ensure the individual stands at the center of their own health and well-being journey? Dr. Michael Petersen, Vice President of Consulting and Chief Clinical Innovation Officer at NTT DATA Services, is joined by healthcare technology expert Frank Cutitta for a conversation on meeting individual needs through personalized healthcare. Because even as technologies and methodologies evolve, one fact remains clear: you are the future of health.
Hey, Frank, it's such a pleasure to meet you, and I want to thank you for taking time out of your day to have this conversation. I'd like for you to just kind of share with us a little bit about your story.
Most of my work, Michael, is related to healthcare technology as a writer, as a researcher, and as a professor. And I happened to get a full dose of the healthcare system after 100 days being hospitalized with COVID in two of the great hospitals in the country, Mass General and it's Spalding. And so as much as I was writing about healthcare and studying it as a professor and as a practitioner, I got to experience it firsthand. And I really, basically, when I came out of a coma for 40 days, I decided that I would start doing primary research from my bed and sort of observing what was going on around me. It was a horrible opportunity, but it was a rare opportunity to actually get involved firsthand and to see how technology was affecting my care and other softer issues related to providers that really either complement or frustrate technology. So that's sort of my background, and a lot of different ways we can go with this.
Sure. So first, congratulations, I guess this should be stated. I mean, to come out of a coma is absolutely, has to have been a life-changing event, not just for you, but your family. More importantly, it was during, obviously, COVID, and it's got to be, can you share a little bit about what it's like? Because I've been a patient myself and a physician. So I've delivered care and received care, and also been a family member who has a loved one receiving care. And it'd be interesting to get your perspective in that you and I have been in this industry. We're studying the interactions and all of the pieces around technology. And here you are, devastated through this experience with your family. Give me a sense of your view based on what you know. What was the experience like in terms of the personal piece of it? And give me a little sense of where you felt there's room to grow, or there's something we're really doing wrong.
You've had your own personal experiences with your family, and how devastating that was as the final result. There's a lot of different observations, when you're sort of a healthcare pundit and you see some of this stuff and then you actually see it in practice, it tends to be magnified. Obviously, we always have to use COVID in titles and things like that with everything we're talking about these days, and probably telemedicine too. They're the probably two most used terms in healthcare technology and marketing these days. What I saw were the magnifying effects of some of these things. First of all, I was brought in at the end of March of 2020 as one of the first 6 people at Mass General that had this, and one of the worst. And so a part of it was that there's a large part of it, despite of all the knowledge bases we have and everything related to artificial intelligence, there was no universe of people that had this for 20 years, like cancer or polio or things like that. So, there was the whole wonder of in a negative way, the wonder of COVID, and people just having to say, we've got the most sophisticated AI systems and machine learning systems in the world, but we just don't know. We just don't have enough people to be able to slice and dice the data to make clinical support decisions. So that was part of it, is that it just reinforced the fact that if you don't have a universe, unless you use synthetic data, which is a trend, you really almost have to wing it. And and as they did with me, they essentially threw the kitchen sink at it. We always talk about interoperability and technology and things like that, and I just was amazed at how magnified that issue was, of how little record sharing was happening, even among, and I'm on the board at Spalding, so I've said this to them directly, even among some of the best hospitals in the world, of how difficult it is to get data within the same organization to get to the people that need it at the touch of a finger tip with the, hitting the return key and seeing that.
Yeah.
I think the third thing that I talk about, and I do this, I have my other business is called HealthTech Decisions Lab, and related to the neuroscience of all this is really looking at how the clinicians look at the dashboard, but they don't look at what I call the driver. And they wheel that cart in every day, and it's fantastic data that they have at their fingertips, but that becomes you. And the person laying in the bed is another person. I use the metaphor of, there's a famous Broadway musical called A Chorus Line. And one of the songs in the chorus line is, "Who am I anyway? Am I my resume?" And sort of the cart is your resume.
Yeah.
And then you're over there waving your hands and saying, "Wait a second, it's me, it's the person." And because of the magnitude of COVID and the loneliness and anxiety and anonymity that was going on during that time, you would sit in your room for 23 hours without being able to talk with people because of the isolation that the clinicians had. So trying to make up for that with technology, even as great as Zoom and as FaceTime is, with your family, it just doesn't replicate touching somebody's hand and saying it's okay. And it wasn't just me. It was the clinicians, the caretakers, frontline people that were going through it even worse than I was.
Yeah. No, I think you're calling out things we've known, right? So I'm old enough to say that I started medicine when you wrote in paper, in charts. And so you would actually have the chart in front of the patient, and you would technically do this during rounds. And what you're describing is these tools and tech and data are providing, and I'm just going to reflect what I think I heard you say, which is, look, you have the best technology, the best things, but it still could be better. One is the data that's in front of me and the interaction that they're having in front of me is a static representation of who I am as a person on this machine. And yet I am in this bed isolated. There's a larger part of what they can't interact with as a result of, even if we just took COVID away and you're an ICU patient and you're out, there's this impersonalization. I would call it a side effect or a downstream untoward effect of the technology. And I think obviously it sounds like, I've known this, but we all know this, it could be better. I do want to get to this part around, I still think, there's a movie William Hurt was in called The Doctor back in the early 80s or 80s, mid 80s, where he's a patient and he realizes that the way he was training his clinicians and the way he was interacting, that it was a horrible system. Where you're describing too, the system is fragmented in that even though you might be going, and you said you talked to Spalding board members around this, is that it should not be the case where you have to go and move your data or get access to data, or that your chart doesn't follow you, or just the interaction, this interoperability. Can you tell me, like, you and I have been talking about interoperability for years, yet this is 2021. What is it going to take to push interoperability so that we can get to a more personalized experience? Because that's the only way that we can get to these individualized journeys for patients if these systems interact and are not sequestered and isolated. Yeah. Tell me what you think about that.
There's a couple points, and I got a couple questions for you too. The interoperability thing is a problem. There was a very smart person I heard at a conference a couple weeks ago that said interoperability is not a technology issue.
True.
And when you really think about it, it's there. It's plumbing. It can be done. It's so highly weighted in politics and gets caught up. So it's really frustrating to know that I had to be moved to another hospital to get a feeding tube out that was trying to be taken out in the hospital one, and I had to go back to the original hospital I was in because they didn't have a user's guide of how it was done. So that's not technology. That's actually connectivity in terms of content. I think the interoperability issue, especially as you start, and you've probably been through this in your career, Michael, when you start getting into mergers and acquisitions across enormous hospital provider groups or payers, the interoperability issues become, to say it's magnified is an understatement. It's seismic in terms of the effect that it has. And that's related to people making it happen, as opposed to, I'm sorry, but these systems just don't talk with each other. We could do some of this stuff using platforms from Microsoft or Apple sharing documents on Google Documents. So it's not that crazy.
What's preventing these providers and the systems and to enable? And we talked about data and interoperability, and I don't want to beat a dead horse because that's where everyone goes to, just like they go to the EMR. I want to see if you could kind of give us a sense of, is it difficult to change these legacy systems that are in place? Is it like some old satellite that only a person in 1973 knows the code to? Or is it something that we can, or is it a combination of factors? Is this something that we can fix?
I think we can, I think it has to do with the peers that help their other peers in terms of implementing and deploying these technologies. I think there are generational aspects to this as well. I mean, we have some of those who are my age who remember Marcus Welby, and then you have Doogie Howser. So, I mean, you have a lot of Marcus Welbys out there. And I've written an article called The Skepticism Maturity Model, where the skepticism about some of this technology goes up as you get older, because you said, I've had 50 years of intuitive knowledge here. So why do I need artificial intelligence to supplement that? So I think the legacy systems are in place because of some of the generational factors. I think we're also seeing this. I mean, we hear it on the news unrelated to healthcare, but I just think the skill set and the workforce itself is not giving us an inflow of the number and kinds of people that we need to have to do this kind of work. It's not for the faint at heart, no pun intended, with healthcare. Yeah. So I mean, just finding informatics nurses, finding nurses, period, but finding an informatics nurse that can translate these issues to other nurses on the ward is a really difficult thing to do. So I think it's translational, sort of a double entendre in terms of translational medicine as being cutting edge, but translational in terms of being able to say, look, I'm 68 years old. And I can do these things, and it does work. So I think there's the skepticism and contrarianism on some of these things is really what holds it back.
Are there cost prohibitive things that are, I would say, inhibiting the opportunity for personalized care, like care at home?
I think when you magnify that across and decentralize that, decentralized care where it's going across thousands of households in replacing the payer, the provider, then it as we knew it, then it becomes an issue. So I think there's parts of this that really have yet to be determined. We also have on the provider side that I just built an entire wing to fit all these new patients in because I didn't have room, and now you're going to move them to hospital at home. So we look at the softer political issues of what do I do with the Cutitta wing at this hospital, and now we're going to take people out of there and move them in other places, and the insurance company is saying, well, congratulations, you built the wing, but we have a lower cost of care and a higher quality of care in some cases with hospital acquired diseases. It's a petri dish in many cases. So you've got those things that payers are going to be leaning on people about.
Yeah, I think it's inevitable, right? You just described an actual problem health systems are discovering that they've, especially if you think of the Boston area where you were at in the hospital system, there is a notion that we may have actually too much property. If the modern hybridization of care, the hybrid model is that pediatricians, we only need 3 of them in office and 16 of them out of office doing remote telehealth, telemedicine. And given that we know that people will consume health and this whole notion of the delivery of care will be remote, et cetera. And I guess there's going to be a couple of themes, right, that are barriers. One is trust. The patients and clinicians believe that this delivery alteration, if you will, is the same, right? You'll have some skeptics, like you said, and we talked about the sort of core beliefs in clinicians. I guess the other piece is the reimbursement model is dated, right? And that has to be modernized or innovated to match these hybridized models. And I think the payers are going to have to be the ones who really set this out and give. I remember listening to some CEOs, some big health systems talk about, look, we quadrupled or 100x'd our virtual care and didn't change our reimbursement. It was as if it was the same. It was, even though we were given the same level of care, though virtually, our billing was not commensurate with our clinician coming into the hospital.
That's a good question. I got a question for you about that. Yeah. So what how do you see, as working in industry and as a practicing physician in your life, how do you see what might be the whiplash of telemedicine, of being out there and people embracing it and loving it, and then people starting to say, it wasn't really bad to go in and I hated the clipboard when I walked into the office, so we could get rid of that. But I really need to have him touch my shoulder or touch my knee. Where do you feel the whiplash is going to be?
I think sometimes these ideas are far ahead of the actual invite. We always say health is slow to evolve. Full disclosure, I don't see patients anymore. I haven't seen one in almost 8 years, but I'm still licensed. Having said that, I do think here's the path. One is, as we develop hybridized models of care, let's think of a mother-baby journey. Most healthy moms, first-time pregnancy, their first part of the appointments, they really don't need to go in the office. You can do a virtual scale or a digital scale, Wi-Fi
Right.
enabled. You can do a telehealth medicine because it's really like, hi, how are you doing? You're pregnant. Congratulations. We confirmed the test that you sent in, that you
Don't
bought
need to
at
see it.
Walgreens or CVS Pharmacy. And also, we've got your weight. We've got your family history. We know based on where you live, the data analytics tell us these are some risk factors for you. Here's what you need to do. Just take your prenatal vitamins and call us if you need us. But we're going to see you in the next month for the next 3 months. But then when you get to week 20 to 27, that will require an in-person visit. And it's designed to enable that if the mom is challenged by transportation or the mom is challenged by childcare, that those are solved by platforms that exist today, social care platforms. And now she can go to the appointment, be touched, do all those things. That's a different change in the journey. What would be interesting and what will likely happen is those who want to be seen in person will. But as we know, we have a generation. I was just at my daughter's dance class, and not one single parent was looking at their kid dance. They were all on their phones, right?
Yeah,
Or if you could
yeah.
imagine plane rides most recently, right? No one's really talking to. So there is going to be, I would say, an affinity for these. Like, I just need to consume it when I want it, how I want it, and not talk to a single person. If you can keep me from having to go to the hospital, I'm incredibly happy with that. And so I think we have to get smart about the generation that is, and how, and meet them where they are, so to speak,
Right.
technologically. I think if you're my mom, Mrs. Petersen, she don't want to do telehealth. She needs to see the doctor. She wants to look. She wants them to look at her. That's her reassurance. So I think I think the whiplash will be less from the clinicians if
Right.
we can match the reimbursement. But I do think there's going to be this preference of being able to pick how and when they work. So 2 days of the week I'm in clinic, 3 days of the week I can do half days at home, and the other, if it's an academic institution, I can do my research. Whatever those things are, they're going to be able to bespoke even the delivery. Now, the challenge will be the shortage, and this is where telehealth, telemedicine will help
Right.
solve for some of this. As we know, the shortages, even if you want to talk to a doctor, there's a shortage of. If I just tried to call a mental health professional today to get an appointment this week, they'll say, "Sorry, we're booked through after Christmas." And I think that we have to figure a way to get people to get the help they need. I did emergency medicine. 80 to 90% of what I saw were not technical medical emergencies, but really were around anxieties and
Mhm.
reassurance around their babies. And, minus the broken arm laceration, most of those were really around a mom and a dad just wanting to be reassured
I
about
agree.
those things. So I think what technology is going to do is going to be able to help people consume reassurance and then save the clinician, save the nurse, save the highly skilled clinician to really see Frank's follow up from ICU care versus I coughed the wrong way and I need to see a doctor because
I think your point about mental health, I think, is interesting, and I don't want to go off on a tangent, but I talk to a lot of clinicians who say it's easier for us to propose to the CFO to get an MRI machine or something like that than it is to get the equivalent in mental health professionals. So people lean towards technology, finance people, and to a certain extent, hospital administrators. I mean, and I'm exaggerating greatly, but I mean, some look at this as sort of the tambourine shakers over people's heads, as opposed to, we can medicate your loneliness away. We don't need another person on staff to come in and do this crazy thing like talk to people over and over again. So it's really, I mean, that's another institutionalized problem that we have to
yep,
look at, and how can technology solve that? I mean, this whole notion of empathic technologies, only go so far with voice enabled devices and things like that, which are critically important. I mean, we all use them. I use them a lot, but those algorithms to replace the mental health aspect only go so far, because you get to a certain point and you say, this machine doesn't know what the hell I'm talking about. Just like when
yeah,
you go on a support line for Wi-Fi, it gets so far, is this, what are you looking for? Is this what you're looking for? No. So where do I go now? Now it's the
yeah,
person. I need the
yeah,
person. And if the person's not there, you're not going to do business with that company.
yeah, yeah. I think it's, again, our health system has to focus on providing that reassurance in whatever way people can consume that reassurance. But also, I don't want to minimize mental health is absolutely part of our model of thinking, in that the full definition of health is not just physical, it's mental or behavioral health combined with social health. And if you think of it in a linear binary
Right.
fashion, you'll continue to fail to help solve patients' challenges, because you might have come in for COVID, but you may have a long history of depression or anxiety. around these things. And anxiety is probably one of the most underdiagnosed diagnoses out there, but it's also prevalent in our everyday world. We see it in how people come in with, it might be more anxiety than it is an actual physical piece, but you have to
Right.
solve for that. But you're absolutely right. I think, again, what we want to do, in COVID taught us this, right? The emergency departments were empty out of necessity for safety, but also at the same time, people who needed to be there still had to go. Like if you had a liver transplant and something happened, you had to go back.
Sure.
What that tells us is that there is a consumption of health that probably can be, I think, allayed. And if we can get people the help they need, when they want it, how they want it, and back to this more personalized experience, I will probably say that those who want to talk to somebody should be able to talk to somebody, and those who feel they can consume it and with an anonymity, because mental health, there's a stigma to it and people are less inclined to have an open discussion. I think we have to have those tools for that. An example I'll give you is there's a survey that was done for patients using RPA, and people are more revealing on the RPA because they know it's not a human, versus when you ask a mom, do you smoke? And we know that there's a large percentage of moms that actually smoke that tell you the doctor.
They don't want to look in the
I
eyes.
lie to my doctor every time I tell him how many drinks I have a week. Just 1 to 2 because Mike, we went to med school together. Come on. I'm like, okay, you got me. Right. Like there's that piece. So
you're right. No, the RPA thing is amazing. But I think getting to your point, I mean, I know one of the key words of what we're talking about here on the podcast is personalized. And I think, I don't want to get corny about it, but the root word in personalized is person. If you ignore the person in personalized care, and you look at that and the intersection of personalized care and participatory care, where they come together. So now I'm sort of controlling my own person in personalized care, and I have a lot more authority than I thought I had in the past. So how do I exert that authority to get the personalized care? To perhaps I was on another call about what do I exert to make sure I'm getting artificial intelligence when it's there, or lean on them if they're not using it. A lot of arguments that you could have about that AI either way.
Frank, having learned your story, I think about your wife and the decision she was provided, whether to withdraw care or to fight. She didn't have any, she probably talked to some family members, et cetera, but there's no machine learning around that decision. But something in her gut, she went with a visceral sensation that said, no, that's not what he would want. I need you to do everything you can. For my dad, based on his age and the chronic things that he had, there was no way he was going to come out of that. But to your point, I think we have to give patients, and this is a paradigm shift in medicine too, and we're getting there, right? A lot of academic clinical professors are talking around this, is just get away from the paternalistic sort of delivery of care and around trusting people to make, helping give people the information to make some decisions for their care. I think it's more simple than that. I think it's really wrapped around providing them the right information and understanding their health literacy so they can ask questions, because that is one thing patients often will respond in surveys, which is, I didn't want to take more of the doctor's time because I just felt it was a stupid question. But to give people that autonomy and the authority to say, hey, whoa. If I'm not at my mom's bedside, she would have had an MRI that she didn't need. It was because I questioned. I said, whoa. You need to go talk to the rehab attending because that's not what we just got told. So I need you to go figure that out. But I can't be an air traffic controller, but that is by default what family members become. I'm sure your wife has air traffic controlled a lot of your care.
She absolutely did. She also knew that I had what I joke around about calling a "you must resuscitate."
It's a different type of DNR.
So they tried to say I had a DNR, and she said no, he has a YMR.
Yeah.
But no, I mean, she was my participatory person there, and she didn't know anything about this, nor did the doctors, because they were still learning it. So nobody had the right decisions, but she just basically had the willpower to say, throw the kitchen sink at it. And we spend a lot of our time now as COVID advocates talking with people all over the world, quite literally, who say, I don't feel like I'm able to get my point across, that we don't want them to be let go, that there is a chance. And I don't want to use my case as a false hope because Frank did it, because that's unfair. But at the same time, when some of these institutions get swamped, they start triaging, and they have to make really, really tough decisions about who's going to be intubated and who's going to be on the vent, because we just don't have a lot of them. So, and that's a harsh reality.
Yeah, I think you're describing, again, around this personalized care theme, that the data is just going to become petabytes. I mean, just overwhelming amounts of data. And what we want as consumers of health is really snackable content that we can say, okay, based on all the noise on my watch or all these things or the decision I can make, and I want my doctor to be able to understand everything that's happening in my personal life because it may impact a decision that this clinician may have. When we think of the Apple Health tool, that now I can share that with a Cerner EMR. Okay, that's great, but for the poor clinician who's going to read about all your diet and all your weight checks and it's no different than when I was practicing. A mom would bring me her diaper diary or her kids' sugars, but I knew, real quick how to sift through that. Clinicians, in the short amount of time that they have and the limited quantity of clinicians we have, aren't going to be able to digest or ingest all of this data. So I do think that there's, from a personalized, if I'm going to come in with this data, I expect them to know about me. And that's one thing we hear in surveys, that you want your clinician to know about you. When you go to rehab, they should know everything that's happened to you. Or if you get discharged and you go to the follow-up appointment, they shouldn't be like, oh, so what happened while you were in the hospital? I mean, let me know. Give me the story. Doc, we have 15 minutes. I need to tell you how I'm doing since discharge. Looking ahead, these organizations understand some of these challenges, and there's traditional, non-traditional. How would you say they should prioritize their investments in some of these advanced technology? And the reason I'll say this, I'll kind of frame it around, there's a lot of noise out there around a lot of AI companies saying we can do this. None of it proven so far, right? I mean, they have some initial things, and there's some great companies, don't get me wrong, but that's a lot of noise for a CIO. How do they say, look, I just need to reimagine the mother-baby journey or reimagine the post-hip surgery journey. Which one of these do I pick and use? And how do I make this experience and bolt it into the existing tech that I have so that the patient doesn't care about what R Python and Salesforce or things that are in the background, but for them, it's a seamless journey end to end. What do you think? What investments do you think?
You just hit it the nail on the head. First of all, there is this sugar rush for AI and all things related to it. So everybody feels that they have to have it, but there's still, I mean, we look at some of the false positive and some of the massive cases of some of the biggest industries in the world that launched this AI stuff that became ineffective. In fact, some of them had to close it down. So there's that part of it. What needs to be invested in? I've been doing a lot of work on, you've got to start using the toys that you already had before we start getting you new toys. And that relates to interoperability. We're not going to add things onto an interoperability struggling organization when we haven't managed to invest in what we have and make that work right, because it's not all broken. It just doesn't talk to each other because, as we said earlier, it could be politics. I think the other part of it is, and this is an enormous challenge right now, is that investing in really smart people in the talent pool. And right now it's a challenge. It's not like the buyer's market it used to be. You've got that problem of just where do we get the people? I'm in higher education as well, and we're just looking at the number of people that really want to get into this healthcare informatics field. A lot of them do. A lot of them are interested. A lot of them want to work their way up their career.
Yeah,
but I mean, we're bringing in more sophisticated technologies with fewer people that really know how to use them, and even if they know how to use them, they don't know how to innovate with them. I think what needs to be invested in, if I were a human resources person, is that we need to invest in risk reward structures that pays people for taking chances. Put money into letting people do that. And it's difficult in healthcare because healthcare is institutionally a do no harm business. So innovation can do harm.
Yes.
So it's not like if I were in auto manufacturing, it could do harm in terms of car crashes, but essentially it's not the same as somebody getting a heart transplant. I think what we need to do is we need to invest in people taking creative disruption chances with the toys that they already have, rather than just laying on top of them.
I love what you say. I call it the Apollo 13 phenomenon, which is what can we do to bring down the carbon dioxide up in space with the stuff that they have. And they have these engineers down on planet Earth putting it together. If you remember that scene in the movie, because it was a real problem. And I think they solved it without having to they didn't fly a spaceship up there to fix it, right? They fixed it with what they had.
Right.
I think that's the case, right? We see, you call it a sugar rush, I call it shiny objects, that there is this, what's the latest and greatest? And if I don't pull that in, either patients will leave or we're not going to have it. And I think what probably has to happen is that there needs to be a pulse check, if you will, to see, do we need, or even just a moment of pause to say, do we need this? Is it going to solve our patient's clinical journey or help deliver better services? what we see is this non-traditional investments, traditional, non-traditional investments are, I think the non-traditional health entities, the redefinition of provider systems are really going to come in and occupy this space because of the seamless experiences they're going to provide. And the traditional ones are going to have to evolve. And if they don't start to think about that now in terms of partnerships, innovative ecosystems, innovative, how can I plug you in to that interoperability piece? So with the last few minutes, I want to give you a chance to kind of summarize this whole theme and tell me, in your mind, is it all that bad, or are we on the right, where will we be in the next 3 to 5 years?
Well, first of all, it's not all that bad because I'm sitting here as a miracle of modern medicine. So for me, from a totally selfish, if it's all about me, it's not all that bad at all. I mean, it's a matter of, can it get better and will it get better? And I do see it that way. I mean, even the authorities on artificial intelligence precede their comments by saying 5 years from now. They don't say today. They know that it has to be iterative because it's the nature of data, that we just can't use today's data for a problem for the Delta virus that happened just but 2 years ago. So I think that artificial intelligence and clinical decision support technologies will continue to increase, and it will start getting data to people on their fingertips. On the other side of it, from the patient side of it, there's the whole technology issue related to patient engagement technology. And the one thing that is, to me, I have to admit, it's like fingernails on the chalkboard, is the digital front door, which I think is, as a digital guy, it just, the words just don't seem to come together, because if you knew how technology needs to work in a provider from the patient's point of view, there isn't a front door. It's like a circus tent with enter where you may and get the data as quickly as you can. So, and I think that's going to improve, because I think the relationship between the patient and technology is going to increase exponentially over the years, especially as you have wearable devices and devices out on the edge, as we like to call it in technology, that are feeding into that central database, if you have one, or into the cloud, which is really the way it's happening right now. So I think that's where we are, that these devices will become more meaningful, and that the insight coming out of them will be orders of magnitude higher than what we have right now.
Thank you for listening to the NTT Health and Wellbeing Podcast. For additional resources and to continue this conversation, please visit www.global.ntt/health and wellbeing.